data are very comparison to what we did to them in terms of radical procedures. The primary endpoint of the study was overall survival, so this was not met. But what we managed to show is that the PFS, which was the secondary endpoint, was significantly better in the PFS. So let me go systematically and show you how the data were, and then we can have time to discuss. So in order for you to remember, the TRUST study is a study of operable patients who are able to cope with radical surgery. This was the uniqueness comparison to the other studies. Also, another uniqueness was that the eligibility would not apply just for patients, but also for centers. Only patients who had a defined surgical quality assurance criteria were able to participate. So it was either accredited centers by national criteria or by ESCO IGCS criteria. And then all of us, so we had a central committee. It was Andres Dubois, me, Sven, and Philip, would travel to all the centers that participated and watch them operate and see that they can actually do what they are supposed to do, so that we don't have the surgical bias of poor quality. So let's have a look at the data. First of all, the quality assurance criteria for the eligibility of the centers was complete resection rates of more than 50% in upfront surgery, and that they did at least 36 such reductive surgeries per year. So it was not illogical to ask this. These are also the definition of ESCO criteria for ovarian cancer centers. We have been very often criticized in the TRUST study that we used unicorn centers, unicorn meaning centers that are, wow, non-existing really, and are only a few in the world. This is not the case. As you see here, the eligibility criteria to participate in the TRUST study was very tangible, was something that could be feasible in many centers across the world. This is the study design. All patients with advanced stage 3B, C, or even 4A and 4B. So four patients, figure 4 patients were allowed to participate as long as the disease was operable. Yeah. And they had to be fit enough to tolerate radical surgery. They would be randomized before the operation, so at the initial presentation to primary versus neoadjuvant chemotherapy. And then they would have chemotherapy. Something very important is that additional trials, systemic trials, the applying bevacizumab and PARP inhibitors was allowed, was okay, as long as both arms had access to it. So we would not, for example, accept a drug if only the primary patients were allowed to have it, or if only the neoadjuvant patients were allowed to do it. So that is why you will also see a big proportion had Avastin, a smaller proportion had PARPs, as long as both arms, and it was balanced in both arms. When we initially designed the study is a superiority study. So it is not a non-inferiority study like the others. It's a superiority study. And we assumed and we thought that there will be a 20% improvement of the overall survival in the primary debulking arm. This is what we assumed would be, and we failed to show that. Yeah, I'm not sure how this line happened. No idea. I don't know who did it. Okay.
I'll try to fix it, but go on.
Yeah, I don't know. I didn't do it. It just appeared. It's fine. So we enrolled almost 800 patients in 3 years. This is massive. So if you see the CORE study, the EOTC study, they recruited less patients in a decade. So we managed to recruit 800 patients in 3 years. Half of them were randomized to primary surgery, half of them were randomized in interval debulking. And you see here the ITT. ITT means intention to treat. We're at the end, 345 patients in each arm. You see here the baseline characteristics. The baseline characteristics are young patients. I mean, you see, we wanted fit patients. There was no upper limit in the surgery. There was no upper limit in the age. So you see here, 83 was the oldest patient in both arms. I think she was mine, actually, this patient from London. Not overtly obese patients, excellent performance status, because that was an eligibility criterion. And 60% of the patients had a stage 3C, 23% in the primary arm, 20% had a 4B, Operable 4B means stroke meds, means intraparenchymal splenic disease, means solitary liver disease, means a paracardiac lymph node, means an inguinal lymph node. So operable things. And of course, something that perhaps has been neglected so far is that 92% of the patients were high-grade serous. So this study is a study for high-grade serous ovarian cancer patients, not for the rest of the histologies. Yeah, rest of the histologies were included, but they were too little to draw any data. Our plan is to bring together our non-high-grade serous histologies together with the studies of EOTC and CHORUS, and make a larger analysis just for the non-high-grade serous ovarian cancer patients. Yeah. So how did the surgery look like? Long surgeries, around 5 hours. So you can see the surgical quality was adequate. Not a lot of blood loss, just half a liter. A very small proportion of, only 1 or 2 units needed to be transfused, so nothing dramatic. And if you see the extent of the procedure, it's actually remarkable to see how little morbidity they had, because 80% had upper abdominal procedures, 30% splenectomies, 60% almost had a bowel resection, 20% a stoma formation, lymph nodes. Something that Renee has asked me, this is a study that started in Germany, in German centers, before the results of the Lion study. So when the study started, the guidelines, the German guidelines by the AGO, they dictated that tumor-free operated patients needed to have a systematic pelvic and parotid lymphadenectomy. And only in the middle of this study, we had the presentation of the Lion results, and then we stopped doing lymphadenectomies. That is why the lymphadenectomy is so high. And something that was very interesting was that 20% of patients would have a chest procedure, either cardiophrenic lymph nodes removal or pleural resection, etc. The neoadjuvant arm had equivalently high procedures, however, lower rate. You see here, stoma formation was 8%, chest procedures was 11%, still upper abdominal procedures were almost 70%, so it was very good surgery and extensive surgery, even though it was in interval. So how was the complete resection rate? 68 versus 79%. And if you take those with documented complete resections, it was 70 versus 85%, just because some patients did not have reported data. More than 1 centimeter were only 10% in the primary arm and 4% in the neoadjuvant arm. And you see here the distribution of miliary disease versus a bit more than miliary disease and bulky disease. So how can we now identify which patients benefit from what? Before I proceed, a sign of the appropriate selection of patients and that the patients were actually strong enough to sustain such radical surgery was that 93 and 97% of our patients were able to proceed to chemo after the surgery. So this means that they did not experience complications in a degree that would not allow them to have chemo afterwards, which is very encouraging and correlates also with low morbidity and mortality. And you see that around 65 versus 60% of the patients would have BEV, and 25 and 30% would have PARP inhibitors. Again, this is a study that we started around 10 years ago. So PARPs were not as available as they are now. So let's have a look at the details. So progression-free survival, statistically significant. You see here 22 versus 19, or 22 versus 19.7 months, hazard ratio of 0.8. So a 20% improvement of the PFS. These are curves that run in parallel. These are not banana curves. So it just continues as it is. And you see here excellent data really after, even after 60 months, which is 5 years, a fourth of the patients had never relapsed. No? So 25% of the patients, you can actually almost call them cured in the primary debulking arm versus around 18% in the interval debulking arm. Overall survival across all stages in the ITT population was not significant. There was a numerical difference of 6 months, which, however, did not reach significance, and the maturity here is adequate, is more than 60%. If we have a look at the forest plot to see whether there were any groups benefiting one way or the other, you see that all the groups were mainly in the primary debulking arm. They were in the primary debulking favoring. There is no single group that stands here. The only group really that is in the middle are the figure 4 patients. So figure 4 patients at the end, it doesn't probably matter when you operate on them as long as they are operated tumor-free. And what we're trying to do currently is to identify the figure 4 patients who are really the bad ones, despite being operable, in order to see whether there is a subgroup of figure 4 that would even benefit more from interval debulking, so that we don't have a higher mortality. You see here the pre-specified exploratory group analysis in only stage 4, so taking away the stage 3. You see here again 23% versus 11% cure rate practically after 5 years. Yeah, because patients with ovarian cancer who don't recur after 5 years, the probability is very low that they will recur. And the overall survival is 52% alive after 5 years in the primary arm versus 45%. So around half of the patients are still alive after 5 years. If we take only the tumor-free operated patients across all stages, both 3 and 4, it's very interesting to see that after 5 years, you will have 26% alive, not cured practically. However, there is a 1 year difference of overall survival, 1 whole year, 12 months, in the primary versus interval debulking arm, which, however, failed to reach significance by 0.0021. So you see here that the p-value was 0.0521. So it was not fully significant, but there is a very clinically meaningful overall survival prolongation across both stages 3 and 4 in the primary debulking arm if the patients are operated tumor-free. Now, this is a slide that was not presented in ASCO. This is a study. This is the curves according to the residual disease, the amount of residual disease. This is PFS and this is OS. You see here that the best curve is the complete gross resection after primary debulking. Yeah, this is the blue curve. You see here that half of the patients were not relapsed, have not relapsed 30 months. It's very interesting. Survival probability. And then the next curve is the green one, which is complete gross resection after interval debulking. And then the two curves together are residual disease after primary or interval debulking. So what this curve really shows is that it doesn't really matter if you leave residual disease. It actually doesn't matter if you operate them upfront or neoadjuvant. So probably the way to go is that when you open up either by laparoscopy or a mini laparotomy, you see you can't get them tumor-free. Don't proceed, close them up, and they have neoadjuvant chemotherapy unless they are in obstruction or they have bleeding, I don't know, in which case you have to fix that before they proceed to neoadjuvant chemo. Overall survival actually pretty much the same. You see here a best curve is complete gross resection after primary surgery, followed by interval debulking surgery complete. And then the two curves of residual disease, again, they meet here, they're banana curves. Again, it doesn't really matter also for overall survival in terms of having residual disease. Now, something again that you have not seen, we asked the statistician to show us what's happening to those patients who had the laparoscopy before the operation. So not all patients had the laparoscopy before the operation. There were, for example, the French centers who did, or in all patients, they did a diagnostic laparoscopy. We didn't do that, for example, in Germany. We didn't do that in England. So we wanted to see whether diagnostic laparoscopy increases the complete resection rate at primary debulking. This was not the case. It was 75 versus 68%, not statistically significant. So yeah, but I mean, this was not a pre-specified analysis. This is not something that is randomized. So it has massively selection bias. There is no discussion. It just gives us a flavor that even without laparoscopy, 70% of the patients can be accurately assessed to be operated tumor-free with the imaging alone. So let's have a look at the morbidity of the operations. The morbidity was different. It was 18 versus 12%. If you see in both arms, the morbidity and mortality was massively lower than the Chorus study, than the Scorpion study. It was very interesting also for us to see. Real laparotomy, I always quoted to my patients, real laparotomy rate is around 10%, and we see here it's only 6%, 6 versus 4%. Readmittance, I also always quoted to my patients 10%, was only 3. Anastomotic leak rates, very low, 3.5% versus 2%. So if you look at this data, they're somehow they're very low. So that was actually very encouraging. And if you see the trust, the quality of life, there is no significant difference at quality of life at any point. So a bit higher radicality did not have a negative long-term impact on the quality of life, as in any quality of life study in surgery. You see there is a massive drop the first 3 months, yeah, and then 6 months after the operation, really the patients have a better quality of life than before the operation, just because they don't have cancer anymore, yeah, and then it increases till it starts dropping again because of the relapse. I mean, yeah. So what are the conclusions? The conclusions are very clear. The primary endpoint of the study was not significant. Yeah, primary debulking, interval debulking, same overall survival. There is a numerical, clinically meaningful numerical difference in the tumor-free operated patients, which, however, failed to reach significance. TRUST is the first randomized trial that really shows that there is significant PFS benefit in the primary debulking arm, moderate but significant. Observed benefits were linked to high complete resection rates, and what was very interesting to see is that the associated morbidity, mortality was the same between the two groups, the mortality, and also the same quality of life. And this is why actually this TRUST is the biggest proof that ovarian cancer patients need to be operated within controlled environments with the importance of quality assurance programs. So I think we have half an hour to discuss. I will not stop sharing so that you can still see curves if you need to, and I'm open to questions.
Okay, and this magnitude, they are never easy. So it's really admirable for you and your whole group to accomplish this. So we do have a few questions. So first, I would like to make some questions on the data you just showed, as just for clarifying purposes. So you mentioned that there was more than 20% 4B in both arms. And from the procedure, pericardial nodes, pleural disease, right? And perhaps a spleen disease. But from that almost 70% that you wrote the on upper abdomen surgical procedure, like we don't have the data on what other procedures are you talking about. We, of course,
Liver
can
resection,
imagine, yeah, how much liver resection or pancreatectomy, that was like the question. This big gastrectomy, do you have the data for that?
I have the data for that. I have the data for that, which are the initial data. I have the data for that. I will need to look for them. I have the data for that. It was not very high. It was not very high. It was
Yeah,
it was not.
I imagine that was why
Keep
it wasn't
going, and
written.
I can see it's not. They are not very high. Let me have a look. This was the initial before we corrected it. Give me 1 second.
Yeah.
Give me 1 second. It was not very high. It was, I can't find it now, but I will find it on the course. Keep going and I can search it in the meantime.
Okay, it's okay. Um, okay, you already talked about lymph nodes. Yeah, when talking about intestinal dissections, it is inevitable to notice, well, that the primary debulking arm had fairly greater percentage of stoma formation. You showed us 20
Yeah.
versus 8, I think, which some can think it's a high rate, at least greater than some published data before
Yeah.
that accounted it for 8 or 13% or so.
Yeah.
So the question is, if you find this percentage high, is
Yeah.
it because you go
Yeah.
further on
Yeah,
resections in
sorry,
comparison
Angelica,
to?
sorry. I have here the liver capsule. These are
Okay,
original
okay.
data.
It's okay, it's okay.
So it is 25% was liver capsule, liver parenchyma 7%, splenectomy, hepatic lymph nodes. This is the breakdown.
Oh,
Yeah.
okay, okay, okay.
Okay. So in
Thank
terms
you.
of the bowel, yes, the majority of the stomatas, where I forgot to say that, was reversible, was a protective stoma. So it was not a
Okay,
permanent, it was just a protective ileostomy. We will
okay.
get to the final presentation, this data, but so we don't have them yet, but the vast majority were just protective stomata of a primary anastomosis.
Okay, and did you have some rules for living in stoma, like number of resections, or if it was too low, the rectal resection, or just the surgeon decided?
It was the surgeon decided. Every center had different. I mean, my personal low stoma rate is also less because I don't do protective stomatas. Yeah. But
Okay,
many centers have as a policy to do protective stomatas always or have
okay,
a lower threshold. So yeah, it was
and do you
completely up to the center.
okay, and do you have the data for when did you revert the stoma? Do you do it
We
after
don't have this data.
chemotherapy?
We don't have
You
this
don't have.
data. We don't have this data. No, I don't think we will get this data.
Okay, thank you. Okay, so, oh yeah, the rates of complete titer reduction for both arms was outstanding, especially compared, as we know, to the other trial subject of this theme, but which also reinforced the importance of the experience and excellency of the high volume center selected. But I have a doubt because on the data you presented, what is the difference between documented complete resections in operated patients, what does it stands for, when you compare it with complete gross resection? Because they are similar, but they're not completely, well, the
The same.
percentages.
So there was a percentage of patients who did not have
Over there.
residual disease reported. You see here? So
Uh-huh,
if you
uh-huh.
take those out, it's this.
Ah, okay, 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 yeah. 'Cause we had like this
Yeah.
questions. Oh, okay, thank you. Okay, we have another question over here on the chat. Wait just a second. I saw it. Oh yeah. If you have how many patients were excluded after the laparoscopic evaluation? If you have that data in
We
which
don't
you
have
showed.
this. We don't have this answer. So what we had said in the patients, what we had said in the protocol is not as soon as the patient gets randomized, one way or the other, she should not be excluded because of the laparoscopy. So it was so the laparoscopy happened for histological confirmation or because it was a policy, but the dictate was not to exclude them after the randomization. Yeah.
Okay.
But again, this is something that we have to look a bit more into data, whether we can get them. But yeah.
Yeah. Okay. Um, okay, so another question. Okay, talking about the main results. Um, do you agree with the concept, or is it fair to say that this is a negative trial regarding like the primary endpoint, right, which is overall survival? And do you think with these results, the standard of care should change? That is making the decision of neoadjuvant chemotherapy versus primary cytotoxic reduction more even. And on the same line, what are your thoughts when in high volume centers like yours, there are almost 30% of patients for which complete site reduction still cannot be achieved. So if you have 30%, you cannot guarantee this complete site reduction, and you have neoadjuvant chemotherapy in terms of overall survival. What are your thoughts on that?
Yeah. So these data are not surprising for me in terms of the 70%. Nobody, not the best surgeon in the universe, will, if they don't highly select patients, they will have more than 70%. There are centers that report 80 or 90% complete resection rates, but then you do an over selection of patients and then you leave out many of the patients. Yeah, at the end, I mean, you leave many. We know the US data, we know the UK data. There are percentages of 40 to 50% of ovarian cancer patients never being operated, never, not even a bit, just because of the fear. Okay, so as you see here, if you take together, only 10% of the patients had more than 1 centimeter residual disease. So practically, if you go by the optimal definition of optimal debulking less than a centimeter, it was 90%. Yeah. So these are relatively good data. In terms of whether I will change practice, so what this study has showed is that the timing of the operation in terms of being detrimental to give neoadjuvant chemotherapy in a fit operable patient and not to operate her upfront is not detrimental. It's not as bad as we thought it is. However, we cannot withhold the information of the patients that there is a year survival improvement in the primary debulking arm if they're operated tumor-free and they do well after primary debulking. So none of us has a crystal ball. Yeah, none of us has a crystal ball. I think what the change will be, at least the change in my practice is that so far, when I opened the patient with primary surgery and I saw I can get her tumor-free, but with less than a centimeter, I continued because I thought that leaving her less than a centimeter is important. I now will not do that anymore. I will just close her up, do a biopsy. If she has a huge mass and she can't see it, of course, I will do it, and then close her up, give her neoadjuvant chemotherapy. I will not go into doing a massive, big debulking surgery and leave residual disease, even if this residual disease is minimal. So this concept of minimal residual disease shouldn't happen up front. Yeah.
Okay, yeah, and when you were talking about the data you showed us on overall survival and the difference in percentages, but still, if you put it in months, we have that the difference for progression-free survival, it's statistical significant, and it's going to be 5 to 6 months when you are looking at stage 3 and completely resected patients, right? But although for overall survival, yes, the months are in between 10 and 12 months, right, of difference, yet it's discouraging that it's not strictly statistically significant, right? So if it's not statistical significant,
12 months difference. It's 12 months.
Yeah,
difference.
12 months for completely resected. And
Yeah.
if you look only at stage 3, it's 8 months, it's 10 months. Yeah. So, but it's still, people argue.
No, the
not
3 months is for all patients. The stage 3 are for all resected and non-resected. It's for both.
Sorry?
The 10 months difference. Yeah, it's for all also for the non-operable ones. It's for all patients. It's not just for the completely.
This one is,
This is
for
for all
comers in stage 3, it's 10 months. And for completely resected, all stages, it's 12 months. But it's not statistical significant. So many people will argue that if it's not statistically significant, can you rely on being really clinically significant? And there's another question, if for all the cohort, the 2 to 3 months of progression-free survival in favor of primary debulking surgery, is that a clinical significant outcome for all comers? that it's going to be 5 and 6 months for completely resected stage 3. Yes?
Yeah. So what we have seen is that no matter when you operate on them, the overall morbidity and mortality is the same, and morbidity is rather low. It's a bit better in primary in interval debulking, but actually not massively better. So it actually pretty much doesn't matter much. I mean, you
Yeah.
have 70% bowel resection versus 60%. I mean, it's in both is high. So I think where we need to go is we need to do by the patient's wishes, patient's symptoms. There are some patients who come to you with very wet disease, very extensive ascites, pleural effusion, who are not great. Yes, they are operable, they are okay, they are otherwise fit, but you drain them, there is 5 liters of ascites, and then they come a week later and they have ascites again. I don't think this patient should be operated. These patients, I used to operate on them, now I won't anymore. I will give them primary surgery. I will give them neoadjuvant chemotherapy. Now, if you have a patient with a big mass in the pelvis, yeah, lymph nodes, not a lot of ascites, can't really go to the toilet because of this big mass, you know, or has a
Yeah.
bowel infiltration, has blood in stool or something where I'm really worried to give her neoadjuvant chemotherapy. This patient, I won't offer her neoadjuvant chemotherapy. I will operate her up front. But I will be very clear with the patient. And then I don't know how it is in your practice here. Many patients in Europe, they come and they already know what they want. They say, I don't want this inside me. I want to have surgery. Or they say, it's all too much. It's a lot of surgery now. I want to have a time to think. I want to have some break first. Let's have some chemo. So we need to respect all that. So what I currently say to the patients is to present them both. I will give them a direction if I feel one way or the other. So I would not give neoadjuvant chemotherapy in a patient with bowel, you know, with a histologically confirmed. But some patients come with a colonoscopy and the tumor is already in the bowel. I will operate on them because I'm very worried of a bowel perf. Yeah.
Mm-hmm.
But this very wet disease
Yeah.
where we need to do dramatic things in the beginning, not necessarily anymore. We can give them neoadjuvant chemotherapy.
Okay. And what are your thoughts on stage 4B resectable? I mean, like a
Yeah.
lymph node, a cervical lymph node, or an inguinal lymph node. But an abdomen, it's totally resectable. What are your thoughts right now with this data? Would you change your approach, or would you
No, I
maintain
don't
a
want to
primary
say
care
anything.
reduction for these patients?
I don't want to say anything because we are waiting with a statistician currently to tell us, as I've said in my talk, which of the stage 4 patients are those who are bad. So let me show you something. If you see here, this, no, sorry, this is complete gross resection. I don't want that. I want this. So if you see, is this the primary? Sorry, is this the, give me 1 second. This is the overall survival. If you see here, the first month,
Yeah.
there is the interval debulking is better, and then they cross. So there are some patients here which are doing this. Do you see this little nose? Do you see the nose? So practically in the beginning, they're the same, and then there is a massive drop in the primary arm. So we want to see which patients are those who do this massive drop. And then see, I mean, I haven't shown you now this data, but this massive drops comes only from the stage 4 patients. So we want to see which stage 4
I'm so sorry,
patients are
Dr.
those ones.
Fotopoulou. We lost the signal for
Can
a
you hear
moment.
me?
Could you repeat that? Yeah, sorry, we lost the signal for a moment. Could you repeat
No, don't
that?
worry.
You were talking about the
Can you
test?
hear me now? Can you hear me
Yes,
now?
yes. Well, I'm sorry. Yes.
Okay, so there is here a nose. Do you see this little nose?
Yeah.
There is a patient which fall drastically in the primary arm. Something is happening, and we don't know what. So we want to identify who those patients are. And those patients are mainly the stage 4 patients. I personally think they will be the wet stage 4 patients, so mainly the stage 4A patients. So we want to wait for a bit more analysis. Alexander Royce, our statistician, currently is doing a bit more analysis.
Yeah, I agree. Or is it rather that maybe it's a 4B disease because it's a systemic emergency or complications, or just the worst patients, as you call them?
No, I don't think it is. I personally think it's the stage 4A disease, but I don't want to speculate. I have published a paper 1,000 years ago of thrombosis and embolism in after advanced ovarian cancer surgery. And we have seen that patients with advanced stage 4 disease who were operated had a higher risk of embolism, pneumonias, and they
Yeah.
died initially. So it's not really for the patient, not for the patient, not for the surgeon, tricky to resect a small trocar met or an intrasplenic met or an inguinal lymph node. This is nothing. The problem is these massive volume shifts after pleural effusion, where the patients get pneumonia, they have chest drains. These are the ones who actually break postoperatively. I think it's that, but let's wait till we have the analysis.
Okay, yeah, and for this analysis, do you know, just of curiosity, because we were discussing about the crossing of the survival curves, do you know if we're gonna make different statistical analysis different than long rank test? Because in statistics, when the curves cross, this test is not like the most efficient because it violates some of the purposes when you do log rank test. Do you know if they're gonna use some other statistics, or you have any information about that?
I don't understand. What do you mean? Sorry. I don't understand the question.
We were talking about the cross in the curves
Yes.
with Dr. Pareja sometime, and we were seeing that the statistic method of long run test, that it was the one selected for the trial. When the curves cross, it doesn't perform well. So I wanted to know if perhaps you knew if you were going to, in the search of this causes, if you're going to make some other statistics.
No, we are not. We are not. Yeah, we're not going to make other statistics. We are going to explore which are, as I've told you, which are those patients who make this cross in order
Okay.
to take them out and say these patients need to have neoadjuvant chemo.
Okay. Okay, we have another question over here in the chat. It says, every single patient selected for neoadjuvant chemotherapy had laparoscopic for histological confirmation, or you started chemo without histology?
So the patient started chemo always with histology, either laparoscopically or image guided, but were operated without histology.
Okay.
So I also have operated some patients there that at the end had endometrial cancer, serous, yeah. Okay. Then
Okay.
they had to plow out of the study, yeah.
Yeah, like most of us. Okay. There's another question. If you have any data regarding costs on the two groups, we know
No,
this
we
is
will
not a
never have
cost
this
effective,
data. We
but
will never have this data. We have so many countries. I mean, Memorial Sloan Kettering, just take the American center. They can do all the costs. No, we don't have this data.
okay. So you mentioned you do not do laparoscopy. So for stage 3C patients that do not have recurrent ascites, what you just talked about, this wet patients, would you always recommend upfront surgery?
No, not always. I will have a look at the images. I mean, nowadays, the TRUST study was a study that happened many years ago. So we usually had only CTs. Now we do diffusion weight MRs. We have so much more advanced imaging than we used to have. And also we have specialist radiologists who learn with us. And I think it's very important to find ways to adequately select those patients in advance. Even a stage 3B patient can be inoperable if they have miliary disease in the entire mesentery.
Yeah,
So it's not
that's
about
right. It's not only about
Yeah,
the
the
stage.
stage. Yeah,
Yeah,
yeah.
yeah. Okay, we have another question over here. It says, I'm going to translate this. How do you explain that after achieving a higher percentage of optimal cytoreduction for the neoadjuvant chemotherapy group, you have a better PFS in the primary surgery group?
The difference between the primary and
Yeah, it was not
the ID, yeah, was not significant. It was
yeah, it
like
was not
70%. So it wasn't really different. Yeah. I always have believed that primary patients do better just because we see all the disease, whereas after the neoadjuvant chemotherapy, you don't see all the disease, or we see scar tissue, we think it's scar tissue, we don't resect it, and it can't. Yeah, I thought always that is why the primary patients will do better. No, okay.
Yeah. Okay. And for your personal practice, which are the studies that the imaging studies that you personal do on your practice?
Well, we have CT in all patients, CT chest
Uh-huh.
abdomen. Yeah. If we have a younger patient who wants to achieve fertility sparing treatment, we will always do an MRI.
Okay.
And we now have done also a study. This is the MROC study, which I hope I can present you the results next year. It's a study where we compare conventional CT with diffusion weight MRI to see whether there are any differences in operability. There we have cost analysis to see. So I will show you the data, I hope next year. If Renee
Okay.
invites me again. Oh.
Okay. Let me see what else do we have over here. Yeah, we have another question. Just if you could remind us, what were your thoughts about the lymph node resection? Why was the percentage so high?
I explained why.
Yeah,
I
yeah.
explained why.
Yeah, could you remind us, please, about it?
It was the day the study started in Germany, and before the results of the Lion study. So it was part of the German guidelines. All patients had to have systematic lymphadenectomy.
Yeah, but the first results presented on ASCO were on 2017.
Of
So
Lion.
of the Lion trial, yeah.
Yeah. Yeah.
2017, like a year after the recruitment of the trust study started. So
No,
all of those
that is
patients.
not. No. The study finished recruiting 6 years ago.
Yeah, the trust study finished recruiting on 2019, right? And it started in 2016.
16, yeah. So the
Yeah,
Lion study came
but the Lion
came
study,
later.
yeah, it was published in 2018, but the first ASCO abstract was presented on
Yeah, so it was a
2017.
year later. So the study
Yes.
was recruiting for 3 years, and half of the time, or a third of the time, had systematic lymphadenectomy. The
So
rest,
that accounted for the
of
70%.
course, but on the other hand, you also have bulky nodes. I mean, we don't only remove systematic lymph nodes, you also have
Yeah,
bulky nodes.
and you have the percentage of the bulky nodes versus systematic lymphadenectomy. No. Okay. Okay. I don't know if there's someone else. Dr. Pareja, you want to make a question?
Yes, I do have a question. Chris, what about the difference regarding the number of ostomies in every group? 20% in one group, 8% in another group. And how this wasn't reflected in quality of life. This is the most interesting part to me because upfront debulking surgery is associated with more complications, longer hospitalization, but you couldn't find any difference in quality of life. This is amazing.
I have my answer to you is that the human body, once more, we have seen how resilient we are. Do you remember the Lion study where the difference in complications was massive? Was like triple the mortality,
Yeah.
And despite of that, the quality of life was the same. Do you remember? So exactly the same. So my answer to you is that we possibly don't have the right quality of life measurement tools, possibly.
Okay.
Yeah,
Okay.
that is first. And second is that if you have such a big laparotomy, whether you have a bit more or a bit less probably doesn't matter, just because it's so big overall. It's like having a flood. It's like a drop more or less. We have done the SOCA study in the UK. The SOCA study in the UK, can you hear me?
Yes,
The
absolutely.
study that we have published a couple of years ago in the British Journal of Cancer, where we have compared non-randomized, very radical surgery versus simple surgery, less radical surgery for advanced ovarian cancer. No difference. No difference. Long term, no difference. The patients get adapted to a stoma, they get adapted to whatever they have. It's very interesting to see that.
Okay, thank you very much. Maybe you're right. We don't have yet the right tool for evaluating quality of life issues, or perhaps we are overrating the quality of life, and all the patients at all will recover from their diseases. I'm not sure.
Yeah, well, I think when a patient has, don't you see that from your daily practice? The patients they never want to have a stoma, never, yeah. But when they have a stoma and then you meet them 3 months later, they don't even want it reversed. They say, oh, it's fine, I got used to it. It's so often this.
Yes.
So the human body adapts, the human soul adapts.
Yes, you're right.
Yeah.
Yeah, I think it's selecting the right the right patient. As you said at the beginning, you have to speak to the patient, tell them what the data is, and they will also
Yeah.
help you to decide. Because in my practice, I do have some patients that you see them and they won't tolerate well this is stoma, they get very depressed, etc. But you can almost like say this patient, it's not going to like an stoma. And there are other patients that accept it. Obviously, as you said, nobody wants a stoma, but there are other patients that have a lot of resilience and they do accept it, and it's not traumatic for them. So I think that part of the decision is also like gathering this patients and putting out there that the rate of stoma, if operating them, would be as high as 20% for some, right? And this is part of the decision, I think. Yeah.
Yeah. On the other hand, we had 70% 70% risk of
Yeah.
70%
In
rate of bowel
the
resection,
interval that
and
we're.
only 10 or 20% stoma. So the majority of the patients actually got an anastomosis. So, and yeah.
Okay, and I wanted to ask you if in your personal practice, regarding the reversion of the stoma, in your practice, when do you do the reversion? Do you do it before
I
chemo,
don't do
after
protective
chemo?
stomata. I don't do
You
protective
never do
stomata.
protective stoma.
Well, I don't do protective stomatas. If I do rarely,
Okay.
then it must be something very tricky, like a clear cell with very low anastomosis, because everything goes extraperitoneally, or a patient after radiotherapy for something else, or a patient after, I don't know. So it must be a very bad,
Okay.
situation.
And you
In which
wait
case, I will
for
wait for 3 months. I will wait for 3 months
3 months. So you wait for the chemo
to finish.
and
So, yeah.
you stop the.
So it depends on what stoma it is. If it's an ileostomy, can you hear me? Can you hear
Yeah.
me?
Yes, we can hear you.
If it is an ileostomy and the
Yes,
patient,
now I can hear you. Sorry.
yeah, if it is an ileostomy and the patient has many volume losses, I will try to do it more. I will do it like 6 weeks. If
Okay.
it's so it depends on the patient. It depends. If it's a neoadjuvant patient, then I will let her finish the 3 more cycles or 2 more cycles of chemo and then reverse. It depends.
Yeah. Okay. Okay. Okay, Dr. Fotopoulou, so it's 8 in the morning. I don't see any more questions. Thank you for your outstanding presentation. It's a very, very important surgical trial. We were all waiting for it. We will wait for the complete manuscript, and of course, this
we are writing now.
analysis. Or you're writing, yeah. Okay, and for this further analysis that will come up, it's very, very interesting. And congratulations again, and thank you for having us and for giving us your time. We are very, very honored. And thank
The
everybody
honor and pleasure was mine.
for assisting today.
The pleasure and honor was
See you
mine.
next
Thank
time.
you so much.
No, thank you. Bueno,
Thank
muchas
you.
gracias a todos.
Thank you.
Entonces damos por terminado el seminario y recuerden que va a quedar grabado por parte de la asociación. Mil gracias. Bye, Dr. Fotopoulou. Have a nice day.
Bye.
Bye.
Thank you. It was an honor. Thank you so much. Bye.